Good afternoon, everyone. Welcome to a webinar on family therapy and overview brought to you by the Indian Association of Clinical Psychologists. My name is Bharat Iyer on behalf of Pearson, and I will be your host for this webinar. I would like to thank all of you for joining this webinar. We have a very interesting topic and a very special guest today. Before we begin, please allow me to introduce today's webinar presenter, Dr. Ahalya Raguram, who is an eminent clinical psychologist and former professor and head of Department of Clinical Psychology at NIMHANS. With over 30 years of experience, she's an expert in family and couples therapy with extensive research in the space. She has multiple awards that she's received along with accreditations and has published many research publications and co-edited 2 books. Now, before I hand over the presentation to Dr. Ahalya, we have a few words from Dr. Kalpana Srivatsava, President of IACP. Dr. Kalpana, please go ahead.
Yes, thank you, Bharat. And thank you everyone who have just joined in. And I welcome Dr. Ahalya Raguram, professor, ex-professor and head of the Department of Clinical Psychology, NIMHANS. Ma'am has kindly consented to speak on such an coveted topic, I would say, because in terms of the training in the Indian context and in terms of the orientation in the Indian context, we find that hardly any kind of a formal training is being given. However, the students undergo a lot of training at the institutes which are recognized by the RCI and where the MPhil programs are being run. So especially this becomes very relevant, highly relevant for the practitioners and the students to have navigate through the various stages and steps of family therapy. Despite of her such rich experience and such busy schedule, when I approached her to impart this set of knowledge to the fellow audience, she consented, and this is really great. And in fact, I really appreciate that giving so much of a time to the professional and the field in the country, that is clinical psychology. So over to you, ma'am, to further enrich the audience. And thank you very much for being here. Yeah.
Thank you, ma'am. Dr. Ahalya, thank you so much for joining us here today. I request you to please take over.
Yeah, thank you all. And it's a pleasure to be addressing a group, even though it's a little unsettling because for the first time, perhaps I'm addressing a group or an audience that I can't see. And that's something I guess we all have to get used to in these times. Anyway, coming over to this topic of family therapy itself, I'd like to just start off by highlighting a couple of differences between individual and family therapy, because many of you might already be engaged in the practice of individual therapy of various kinds and might have some level of familiarity and experience with it. But I guess the number of people who are actively involved in family therapy might be somewhat lower than that. So it would be useful to set out some of these differences. In the first place, when we talk about family therapy, we need to remember that it is basically a generic term to refer to a wide gamut of different approaches and techniques, just as we have different approaches and schools of individual therapy. Likewise, there are similar schools and approaches in family therapy as well. One of the differences from individual therapy is the fact that family therapy tends to focus a lot more on the process of what's actually going on in sessions rather than in the content, that is in terms of what people are saying to each other during the session. And most importantly, one of the most important differences is that there's a great deal of attention given to the particular context in which a behavior occurs. I can give you a simple example for this. If we take a phenomenon like anger, now, unless we know the context in which anger has occurred, it would be the kind of meaning that we draw out of it, or the kind of importance that we give to it, can vary greatly depending on what are the circumstances or the context in which anger occurs. For instance, supposing somebody has had a very bad day at work and then comes home, and some slight provocation at home triggers off a bout of anger. There is a certain meaning that we can attach to that. We interpret that anger in a certain way. On the other hand, there are also some individuals who, when they are tired or fatigued or hungry, also tend to be quite irritable and prone to losing their temper quite easily. Now, the kind of meaning or interpretation we make of that anger might be very different. So in this sense, many of the behaviors, although at a superficial level may appear to be similar, yet the meaning and the significance of those behaviors can vary depending on the context in which it occurs, and family therapy pays a lot of attention to this context. The third important difference is that while in individual therapies, we tend to focus on the individual developmental trajectory. We trace what has been the development of the individual across different life cycle stages. In family therapy, a similar effort is made to track the evolution of the family through different phases. Now, what are these phases? I will just very quickly mention them because we really don't have time to go into each of these stages. So the first family life cycle stage would be the unmarried couple without children. The second would be the young couple with after the birth of the first child. Then the third stage would be the family with preschool age children. Then the family with school age children, families with adolescents, families in the middle years and leading on to the empty nest, and finally families in the later years. So very quickly, these are some of the life cycle stages as far as the family is concerned. And it is important to remember this because I will touch upon this again a little later in the presentation. So coming to actually what family therapy is, in a very broad sense, we can understand it as a specific way of thinking about human behavior and problems. And one of the overarching approaches or the framework that is currently most widely used by most family therapy practitioners is what is known as the systemic approach, which includes a set of therapeutic techniques for treating family distress. Now, I would like to spend a little bit of time in highlighting some of the main concepts that are embedded in the systemic approach, because this may not be familiar to everybody. However, I would recommend that in order to understand it better, it is important to supplement this presentation with also reading up a bit about the systemic approach. So firstly, we need to understand what is a system. In this context, we are referring to the family as a system, which essentially means a set of units and elements. In the strict definition of a system, it refers to a set of units and the elements that are organized, interdependent on each other, and which have interactional relationships with each other, and systems have boundaries. In the context of a family, what this really refers to when we are talking about units and elements are basically different family members, and within the family, different groupings of family members. These Groupings within the system are often referred to as the subsystems within the family. So, for example, the husband and wife in the family together form what would be referred to as a marital subsystem. However, our children, then they are also a parental subsystem. Likewise, siblings form a sibling subsystem. You can have multiple subsystems within a family system. Like, for example, you can have a subsystem which comprises of all the male members of the family or all the female members of the family, and so on and so forth. And people can be simultaneously a part of different subsystems at the same time. The family system itself is part of a larger ecosystem, which is referred to as the suprasystem. Like, for example, the family is part of a neighborhood, it is part of a particular community group, a linguistic group, or a religious group, and so on. So the family system can be part of a number of larger systems referred to as the suprasystems. We understand or we recognize the presence of a system because of what is known as a boundary around the system. In fact, it is the presence of the boundary which defines and identifies the existence of a system. Now, what are these boundaries is something we'll talk about next. This is basically a hypothetical construct when we are talking about boundaries, and what it essentially refers to are certain rules that exist in all families. Rules regarding actions, behaviors, and emotions. These rules may be either explicit and sometimes they are also implicit. But the important thing is that these rules are and these interactions are repetitive and occur regularly over time. There are also different types of boundaries. Basically, three types are described. One is what is called open and clear boundaries, which essentially means that the presence of this boundary around a particular subsystem regulates the flow of information outside and into that particular subsystem. On the other hand, there is a closed and rigid boundary, which means this boundary prevents or curtails the exchange and flow of information across different subsystems. And then finally, there is the third type, which is the diffuse system, where the existence or the presence of a boundary itself is very unclear. Now, I think a couple of examples will probably make it a little clearer. If we are talking about an open and a clear boundary, essentially it might refer to a family system where you have parents and children, and the interactions, the communication, the exchange of ideas and information happens in a very free and transparent and honest manner. On the other hand, if the boundary is a very closed and a rigid one, then it is likely that maybe parents do not share any information or have very, very minimal interaction with the children in the family. If there is a diffused boundary, it means then that there is no clear line of separation between parents and children, and it is quite likely that parents are over involved in the lives of the children, and whatever happens to the children or vice versa has a kind of a destabilizing effect on everybody else involved in that particular subsystem. In other words, there is too much of an emotional and a psychological closeness, so that any event or anything which affects one member has a disproportionate effect on all the other members involved in that particular in those particular subsystems. Likewise, the boundary around the family system and the larger suprasystem may also be either an open one or a closed and a rigid one or a diffused one. So if you have a family which has a very closed and a rigid boundary, it means external boundary, then it means that these families are likely to be quite isolated. They may not necessarily have too much of interactions or communication with people or other systems outside of the family. On the other hand, if it is a diffused external boundary, then you have a situation where anybody from outside of the immediate family system gets easily involved or drawn into the particular family system. And this can be a situation where perhaps external or the extended family members tend to get involved in the index family, maybe interfere and generally cause difficulties and problems as far as the index family system is concerned. And this is a very important concept as far as family therapy is concerned. Now, the systemic perspective, the other very important characteristic of systemic perspective, emphasizes what is known as the circular causation. This is in contrast to the individual therapy perspective, which in general tends to emphasize a linear perspective. So when we say linear perspective, we might say that there is an individual who has had perhaps very difficult circumstances while growing up, and that tends to shape that individual's coping styles in a certain way, which might become manifest whenever they face other adversities or difficulties in their lives. So in that sense, there is a linear cause, a linear link between their earlier experiences and their current styles of functioning. In family therapy, on the other hand, what is emphasized is circular causation, which means to say, again, I will use an example for this. If there is a mother and a child who are interacting, supposing the mother scolds the child for a particular undesirable behavior. Now, it obviously has some kind of an effect on the child or on the adolescent. And let us say that the mother was rather harsh in doing so. Now, the way in which this adolescent responds to the mother, the response can be anything. It can be either that the adolescent gets very angry and withdraws, doesn't communicate, doesn't talk to the other family members, or it could be that the adolescent in turn responds with anger and so on. But what the family therapy or the systemic perspective would be interested in is an understanding how does the adolescent's response in turn affect the mother. So again, it could lead to either the mother becoming even more angry or upset, or she might become very anxious about the future of this adolescent, or she might become depressed and worried that the child's development is not proceeding along expected lines, and so on. And this idea of circular causation, that is to say that there is a reciprocal sequence of interactions which is focused on. Here I've used the example of just two individuals, but in a family system, there will be obviously more individuals involved, and the systemic perspective is interested in understanding and tracking the circular causation. How does the behavior of one individual impact others, and how do their responses in turn impact the individual, so that it is a circular pattern that we are talking about. There's also another concept in the systemic perspective, which is called the equifinality, which is also linked to the idea of circular causation. Equifinality is very important because it has it's a very useful concept because it has a lot of implication for intervention. Now, if we are talking about a circular pattern of causation, then it really means that in our intervention, we can intervene at any point in this cycle. That is to say, we can intervene with any individual in the system. And if there are changes introduced in that one particular individual or into that one subsystem, then it definitely will have a spillover effect and impact the others. This is useful because at times it may not always be possible to involve or elicit the cooperation of the person who is considered to be the index patient. And sometimes therapists might feel stuck if they find that the index patient is not really cooperating. As far as family therapy is concerned, this is not an obstacle or an impediment at all, because you can still begin the intervention by working with the parents or the siblings. And by introducing change in their responses, the index patient is in some ways drawn into also making corresponding changes. And that is a useful idea that the systems perspective embraces. So to elaborate a little further on this idea of circularity, it essentially means that behaviors and beliefs are embedded in an interrelational context. Individual behavior is best understood in this context. Reciprocity in interactions is crucial, and interactions serve to maintain dysfunctional patterns. These are in some ways summarizing some of the ideas that I have already talked about a little earlier. Now, in systemic approaches, the way in which the problems or the dysfunction in the family is understood is by formulating at the end of the assessment process what is known as a circular hypothesis. Just as for all individual therapies, once we have elicited whatever is the required information, we try to formulate a model of psychopathology which helps us to understand and organize the information that we have obtained. Likewise, the circular hypothesis is a similar exercise of putting together all the information that we have obtained in the assessment sessions into a kind of a hypothesis which helps us to understand what is it that is going on in the family currently, how has it evolved over a period of time, and what is currently maintaining this dysfunctional pattern. So there are several things that we need to keep in mind about the circular hypothesis. One is that there is no absolutely right hypothesis. So the therapist need not worry about whether a particular hypothesis that they have constructed at a point of time, whether it is absolutely right or not. Hypothesis by its very definition is something that can be disproved or allows scope for modification and change. Likewise, having formulated an initial hypothesis, the therapist can proceed to undertake certain interventions or introduce certain modifications within the family. What might happen then is that as the therapy progresses, there might be more information that is forthcoming from the family members, and that information can be used to modify the hypothesis. So one need not be in some sense bound by the fact that the therapist feels that they do not have sufficient information, or they have not done a completely comprehensive evaluation, and therefore a hypothesis is not possible. Even after the very first initial intake interview, it is possible to have a very brief working hypothesis to start off with. But the thing to remember about having a hypothesis or formulating a hypothesis is that it should differ from the family's own hypothesis. This is important because whenever families come for therapy, they usually come with their own analysis or understanding of what's going wrong in the family or what has caused the problem. For example, they might say, oh, everything was fine until our son, we changed the school. And then, or once he changed the school, he got into bad company, and that is exactly what is the cause of all the problems that the son is facing. Now, that is the family's own explanation and hypothesis. However, the therapist cannot just go along with the family's own hypothesis. While acknowledging it, they must still continue to obtain further details and information and use that information to construct an alternative hypothesis. Now, the alternative hypothesis in the same example could be that, yes, the family has changed the school of the son was attending, but within the family, what were the other corresponding changes that also happened? Now, it could so happen that because or simultaneously, while this change happened, the father starts spending more and more time away from the home, and the mother is, who may also be, for instance, somebody who's a working professional herself, may not be able to spend sufficient time or monitor and supervise the activities of the adolescent. So, in addition to the change of the school, there are other changes that have happened in the pattern of interactions as far as the family is concerned. And these are the things that also need to be taken into account, because it may be the lack of quality time spent by the family together. It may be the decrease in the monitoring and supervision that was earlier provided to the adolescent. So it might be a combination of several of these factors together which have led to certain problem behaviors, and not just merely the one single fact of change of school, And so that's the therapist's task in collecting the information and formulating a hypothesis or an explanation which is different from the family's own. But the most important thing is that the hypothesis should help us to understand what purpose is being served by the symptoms. I will try to illustrate this idea a little later by using a case vignette. And the hypothesis must also try to answer the question, what would happen to the family if these symptoms or if the particular problem behavior were not to be present? These are important ideas, again, as part of the systemic approach is concerned. And it is the formulation of this hypothesis and the attempt to answer these questions of what purpose is being served by the symptoms and what would happen if the symptoms were not present, which guide the interventions. So coming to the nature of the problems, what kinds of problems really can be addressed in family therapy? Basically, of course, interpersonal difficulties between members. It could be between parents and children, or among the siblings themselves. Marital problems which have an impact on the growth and development of children is again another important reason to seek family therapy. And these marital problems could include sexual difficulties and infidelity. However, there can also be other difficulties for which family therapy may be useful. Some of the major ones are ongoing stressors. For instance, chronic mental disorders, serious mental disorders, such as schizophrenia or bipolar disorders, or obsessive compulsive disorders, and so on. So many of these conditions that are likely to be serious and which are often chronic in nature often benefit by family therapy. Problems related to alcohol and other substance uses, developmental disorders in children. For example, families who have a child that has either autism or other major developmental disorders, again, might require a lot of family therapy, and chronic medical conditions. Some of these chronic medical conditions, again, have an impact on the overall functioning of the family as a whole, and therefore it might be useful to consider family therapy in such instances as well. So coming to the process of family therapy itself, one important step is the intake or the initial interview that the therapist has with the family, and what needs to be done in that particular session. Generally, the first initial interview or the intake interview need not be a very long one. About 20 to 30 minutes might suffice. Of course, after the introduction and rapport building, it is important to understand what are the reasons for which the family has been referred, if they have been referred by some other professional or agency and so on, or have they approached the therapist on their own. Eliciting the family's ideas of the problem. This we talked about earlier. Understanding what is the family's own explanation or hypothesis about the problem. But the most important thing to understand is why now? Why is the family approaching a therapist for help at this point of time? What we need to recognize is that people don't generally approach therapists the very first instance after a problem emerges. Many times families attempt to try and resolve the problems on their own. They make their own attempts, they try out their own solutions, and it is only when none of these things work or the problem gets worse that they decide to seek professional help. But even for that, there is usually one final trigger which results in the family making the decision to seek help. And it is important to try and understand or elicit that. For instance, if there is a situation of an adolescent who has been becoming increasingly angry and aggressive and destructive and so on at home, the family might have tried various means of trying to control the adolescent's behavior or to try and deal with it with their own measures. However, there might be one final act of the adolescent, right? It could be, for example, something where on a particular day, one of the parent completely loses control and really resolves to very severe physical punishment of the adolescent, resulting in maybe the adolescent deciding to run away from home. So after the adolescent has been brought back to the family, that might be the reason why the family has now decided that they can no longer deal with the problems with their own resources and they need professional help. So understanding why at this point of time the family has sought help is important. Because we need to remember that most families are able to function even with a kind of a dysfunctional equilibrium for sometimes months and years together. So something more happens which disrupts this dysfunctional equilibrium, and we need to understand that. The other important task in the initial intake session is also to explain the rationale for family therapy. This is again important because when most families come, they come because one person in the family, who's usually referred to as the identified patient, develops problem behaviors or symptoms or something like that. And therefore, the family comes with the understanding that the therapy or the treatment will be directed towards that particular individual. So when the therapist explains that other members of the family have to be also involved, often there might be a resistance to this idea. And most families will say, oh, there's nothing wrong in our family. Everything is quite all right. And if only this individual's behavior is corrected, or the appropriate treatment is given for this individual, things will be perfectly all right in our family. So convincing them that there is a need for all of them to also be involved in the therapy process is an important part of the intake. Now, this is where the having the initial working hypothesis is helpful, because if we are able to quickly derive a working hypothesis, even with the minimal information that we have in the intake session, that can sometimes create an acceptable rationale for the family members to participate in the therapy. Of course, ensuring confidentiality, coming to an agreement about the structure of the therapy, that is the duration, the payment, if it is involved, and who are the members who would be required, and motivating the family for therapy. These are all aspects that are important even for the individual therapy. Now, once the family has decided that they will proceed with family therapy, the next task is to undertake a thorough assessment of the presenting problems, as well as what are the family dynamics and what has been the family's functioning over the years. So we try to evaluate what is the family's style of decision making, who is considered to be the leader or the most powerful person in the family, how are decisions made, what are the different roles being performed by different members of the family, are they being adequately performed, is there satisfaction with the roles being performed, is there a complementarity amongst members with regard to their role functioning. Of course, communication patterns. What is the kind of communication that goes on between the family? Again, when we are talking about communication, this refers not just to verbal communication, but it also refers to affective communication. What kinds of emotions are generally exchanged between the family members? Is it predominantly anger and other negative emotions, or are there also the more positive emotions of concern, caring, intimacy? Are all these also a part of the communication patterns? What are the adaptive processes that the family has? How do they resolve conflicts, for example? How do they solve day-to-day problems and difficulties? What coping methods do they have, and what resources do they have for coping with difficulties in terms of support from primary family members or secondary supports such as friends and colleagues and neighbors? And lastly, what is the degree of cohesiveness that seems to be present in the family? Do they appear to be a family that is that has a sense of belongingness and a we feeling amongst them? Or is it that members are basically indifferent to one another and they are really not bothered, or they don't care about each other, and so on? So these are some of the different parameters on which we need to evaluate the family. Here, the point that I referred to earlier in terms of the family life cycle, it's important to evaluate these parameters across the family life cycle stages, which means what was the decision making like, or the power structure like, or the role functioning like at the initial stages of the family life cycle, and how did it change through the different succeeding um, uh, cycles of the family life. It's important to maintain, to obtain that longitudinal perspective. And the other thing to remember here is that usually, in order to understand or to evaluate all these different dimensions, we need to keep our focus more on the interactional patterns involved in each of these dimensions, much more than on just merely events that happen. So to facilitate this, there is a particular form of asking questions or interviewing, which is referred to as, again, the circular questions. Circular questions, for example, might sound like this. For example, if you were to ask the family, how close would you say your family is to each other? Then you might get a very simplistic kind of an answer, which might, where the members might say, oh, we are all very close to each other. But if you phrase the question a little differently, and if you were to ask, who is closest to the father? And if you ask the different members about their opinion about it, you'll get a completely different picture. Okay? And likewise, the questions need to be varied in a way that elicits a lot more information about the interactions. Again, circular questioning is a particular style of asking questions. It is important. Unfortunately, I won't have the time to really go into too many details, but I would urge those of you who are interested to read up more about this, because it's a very useful way of asking questions in order to understand really the nature of interactions and relationships that are present in a family. So, having understood what are the family's dynamics, we then decide on what are the goals. Broadly, the goals are to strengthen the family system by fostering growth of individual members, growth of the family as a whole, to strengthen marital relationships, and often enough, there is a lot of re-education that might be required of family members to modify their dysfunctional communication patterns and to enhance their ability to resolve conflicts. Re-education is important because particularly when it comes to dealing to a family that has problems in dealing with children, a lot of parenting skills and educating them about, for instance, what are some of the changes that might be expected during different phases of the life cycle of a child. For example, what changes can be expected during early adolescence or later adolescence, or when children are launching out as young adults. It might be useful to provide some amount of education regarding some of these aspects. However, of course, I need not emphasize that these are broad goals, and we need to have individualized goals for each family depending on their particular problems and difficulties. In general, however, The immediate short-term goals in therapy would be to help the family shift their focus away from the individual to the relationship characteristics, to develop a strong therapeutic alliance with all members of the family, to ensure that there are equal opportunities for participation in the sessions, enhance motivation and foster a sense of hope and optimism regarding the outcome. Now, I'll just focus a little bit on the first 2 or 3 points. Firstly, ensuring equal opportunities for all members of the family. In a family therapy session, it is quite likely that one person may try to act as a spokesperson for the rest of the family. Now, this is something that needs to be discouraged, and the therapist must encourage each member of the family to speak for themselves and give them sufficient opportunity to state their opinions or their beliefs or ideas. This means that the therapist has to be very active in the session to ensure that one person does not dominate and take up too much of the time and not allow enough time for the other members. But more importantly, to also see that all members feel sufficiently safe and comfortable enough in the sessions to open up. Likewise, once there is a working hypothesis, it is important to help the family understand that the problem is not just in the individual, although one individual may be manifesting symptoms or problem behaviors, but the fact that these behaviors are being maintained because of certain dysfunctional interactions that are going on within the family, and therefore that there is a need to change these interactions. Then the other very important point is to develop a strong alliance with all members of the family. This is crucial because it is quite natural that therapists may tend, knowingly or unconsciously many times, to be biased in favor of one or the other individual in the family. For example, a younger therapist perhaps might be more sympathetic to some of the issues of the younger members of the family, and therefore unknowingly might side with that individual and might oppose the parents. Now, this can be very easily picked up by the parents in the session, and then if that happens, they are likely to develop a they are likely to feel that the therapist is on the side of the adolescent and not really being very supportive to their point of view and so on, and that can create a rupture in the therapeutic process. It could also be that a therapist who is himself or herself struggling with, let us say, issues within their own family, let us say with a very strict authoritarian parent, some of those emotions and feelings are quite likely to be aroused in the context of the family therapy sessions also. So it is important, firstly, to be very, very alert and conscious that these kinds of feelings can be evoked in the therapist, and to make all efforts, therefore, to ensure that the therapist develops a strong alliance with all members of the family. The long-term goals are in fact to resolve whatever are the presenting problems for which the family sought help, but more importantly, to decrease the urge to punish. A lot of the interactions and the dysfunction that is maintained in the family is because there is often a need in different family members to punish one or the other member of the family for certain imagined insults or hurt that they have experienced. To encourage, and in order to decrease the urge to punish, you need to encourage forgiveness in the relationship, foster reconciliation among members, and encourage the development of a sense of intimacy. All this is done through discussions that involve different family members. Now, in therapy, firstly, at the beginning of therapy, it is clear to set the stage, outlining some clear rules for the session. One of the major rules being that all members will actively listen to each other. They will not interrupt. There will be no abusive language or any aggressive behavior that can be manifested in the sessions and so on. But the therapist also needs to pay close attention to what is the nature of interactions in the family within the session itself. For example, even a simple thing like observing when a family of, let us say, 4 people come into the therapy room. What is the seating arrangement? Who sits next to whom? It is possible that the parents, each of them might sit at the opposite ends, and the 2 children might be in between. One very initial hypothesis that we could draw is that this physical distancing, does it indicate a kind of an emotional distancing between the parents, and the children are being used as a kind of a go-between or a buffer to deal with their problems? Or it could be that 3 members of the family sit close together and one person sits somewhat at a distance. So a hypothesis could be whether that family member feels somewhat isolated and excluded, whereas the rest of the family seems to form some kind of an alliance amongst themselves. So focusing on and observing what goes on in the session will often give a lot of very useful information. As I said, the focus needs to be not so much on events which have happened in the family, but what have been the responses, the emotional reactions that occurred around various events. The therapist may at times need to assume what we call as a one-down position. We need to remember that often when therapists are young, they are, if it is a family therapy session, they might be dealing with parents who are much older than them and who might in fact be the age of their own parents. So in such a situation, for the therapist to be assuming a position of authority, of conveying the sense that they know or they have all the answers and solutions, may sometimes not be very acceptable to the older members of the family. So it is helpful for the therapist to assume a position wherein they acknowledge that the older members of the family have more experience, and definitely those experiences have value, and that as therapists they are interested in understanding their points of view. If this kind of a stance is adopted, it often makes the older members a lot more comfortable in the sessions. They become less defensive and more ready to participate. And there needs to be a flexibility in the therapy structure, in the sense that although the general recommendation is that all the family members need to be seen together in conjoint sessions, yet there might be certain sessions where it may not be necessary or useful to have all members. So depending on what issues are going to be discussed, sometimes it is necessary to have different combinations of family members and have the therapy sessions with them. But in general, one thing that has to be discouraged is often family members, one or the other, might make an attempt to seek out the therapist and request for an individual session alone with the therapist. This is something that needs to be discouraged, because whatever is the issue that that individual wants to discuss alone with the therapist is something that precisely needs to be talked about openly within the family context if it has to be resolved. So while the therapist can provide some time for the individual to ventilate, at the same time, they must also encourage them and empower them to bring up this issue in the context of the conjoined session so that it can be openly talked about and a resolution of the problem can be achieved. So the important processes to keep track of are, as I've mentioned earlier, track interactions, feelings, and meanings. There will be a pattern of shifting alliances and neutrality, which means to say that the therapist at times can take sides with one or the other member of a particular family or with a subsystem within the family. But this has to be based on a particular need for empowering that particular subsystem or that individual. It cannot be a permanent alliance all through the therapy sessions. It has to be issue based, and the moment the issue has been dealt with, then the therapist goes back to the stance of equal alliance with all the members. Paying equal attention to all members, building hope, we have talked about. Most importantly, avoid blaming the family members. Even if you have identified a family where maybe parents have been very punitive or very indifferent or insensitive, still in communicating with the family, the tendency to blame them or to hold them responsible for the problems in their children is something that has to be avoided, and acknowledge strengths in the individual family members as well as in the family system, because these are the strengths that therapists may need to build on in order to bring about an improvement in the functioning of the family. Just some do's and don'ts, which again is more or less summarizing what I've said earlier. Some of the do's to maintain neutrality, empathy, hope, respect, understanding, acceptance, and emphasizing positive aspects. Avoid permanent alliances with any of the family members, moralistic judgments, false promises, belittling any of the family members, coming to or forming certain theories or becoming too using too much of jargon and technical language and other things in terms of talking about or describing the problem, and of course de-emphasizing the negative aspects of the family. Now, what have been some of the predictors of outcome that have been observed? One, when the family finds it is able to shift the locus of the presenting problem from the individual to the interactions within the family, that generally leads to a better outcome. The quicker there is a reduction in the negativity in the sessions, the more likely that there is a better outcome. And then the quicker that there is improved interactional and behavioral competence within and outside of the sessions also, that is again an indicator of a good outcome in family therapy. The more they adhere to the treatment suggestions that are given, the stronger is the therapeutic alliance, and the more quickly they are able to move past some of the roadblocks that might be encountered during the process of therapy, the easier it becomes. Now, before I conclude, I would just like to give a very brief case vignette, which will highlight some of the points that we've been talking about. Now, this is a case where a 17-year-old boy of upper middle socioeconomic strata was brought by his parents with the complaints that he was becoming increasingly aggressive at home, demanding um, expensive objects, complaints of disobedience, being rude to the family members, bullying his younger sibling, and some instances of substance use, and so on. There was also a decline in his academic performance, and it was found that these problems had begun perhaps about 4 years earlier, but had exacerbated in the previous 6 months. Now, on evaluating the family's dynamics, what was identified was that both the parents were professionals. Now, in the early stages of their marriage, the father had promised the mother that they would relocate to another country where she would have a chance to pursue her ambitions and her aspirations. However, that never happened, and instead, he unilaterally decided to stay back within the country. And in the course of a few years, he also quit a well-paying job that he had in order to start a business of his own. Now, this led to financial difficulties for the family, but more than that, the mother felt completely betrayed because these decisions had been made unilaterally without any discussions with her, and she felt that this was gross selfishness on the father's part and that he had let her down very badly. So there would be frequent fights between them, and whatever may be the issue on which the couple fought about, ultimately it would come back to this sense of betrayal that the mother constantly felt throughout her marriage. Now, the patient and the younger brother had been exposed to these fights for quite a long period of time. And ultimately, it was on one occasion when the father completely lost his cool and really thrashed the index patient that the family decided that they could no longer deal with the problem and they had sought help. Now, the way in which individual therapy might approach it is to focus only on the adolescent and, to teach anger control strategies. But that would be a very limited kind of an approach because you need to understand the context in which this anger had been occurring. Once the family dynamics had been uncovered, it became clear that the pattern that seemed to have happened was that with the constant friction between the parents, the father had started becoming somewhat uninvolved in the family matters. And the mother, in some ways, was using this adolescent child to confide some of her grievances in the marital relationship with him. He was probably feeling somewhat overburdened by this emotional sharing of the mother and not really very keen on dealing with it. Now, if you remember, one of the things I had mentioned was we need to understand what role does the symptom, what purpose does the symptom serve. In this case, what happened was that once the boy's aggressive and assaultive behavior kept increasing in intensity, ultimately the mother sought the father's help in dealing with the boy's behavior because she could no longer handle it on his own. For one thing, physically, the boy was now grown up and she could no longer deal with him on her own. So this resulted in the father being drawn back into the family system, and they began to spend a little bit more time on each other, with, however, the common goal being how to deal with the son's problems. So one of the purposes that can be served by symptoms is sometimes drawing in family members who are uninvolved and thereby averting the breakup of a family that is maybe on the verge of separation between the parents and so on. Not that this is consciously or deliberately planned and done, but the dynamics occur in such a way that this is the result that is achieved. So this was just an example of how symptoms can sometimes serve a particular function. The reason why it was being maintained is because, of course, parents kept yielding to the boys' threats and demands and so on. In the course of therapy, they were empowered to work together collaboratively, to sync and resolve their differences so that they could more effectively handle the boys' issues together as parents, as a parental subsystem, and not as individuals within the family. And that really helped in bringing down the boys' problems. Later, once that had been dealt with, then the other issues, the long pending marital issue, the unresolved issue of the mother's sense of betrayal, that was taken up and addressed. And one of the things that was done was also that the mother had a very deep sense of low self-esteem because she felt that she had not had a chance to live up to her ambitions and dreams and so on. And therefore, there was some bit of an individual attention given to her to enhance her sense of self-esteem, to make her feel empowered, and to help her um, regain her own sense of identity by exploring other options and avenues. Overall, this then led to a much more peaceful and harmonious environment within the household. And this also led to the father becoming more and more involved. And the family was then able to spend much more quality time together than they were previously using. So in conclusion, we can say that family therapy is not just about resolving problematic relationships, but also to enhance healing potentials in the relationships. Often in couple therapy, a good resolution to the problem can be when the couple recognize that they can no longer sustain and continue their relationship, and that it would perhaps be in their best interest if they were to separate. But in the case of family therapy, as I mentioned earlier, the the best outcome or the desirable outcome is where the healing potential in the relationship through um, helping um, helping the family forgive partners and other members for past hurts that they may have experienced in the relationship, and finding ways of reconciling and thereby sustaining the relationships is what can be considered as a good outcome in family therapy. I think I've exceeded my time quite a bit, but thank you all for a very, very patient hearing.
Thank you so much, Dr. Ahalya, for that very insightful presentation. We will now be taking the questions from the audience. I also invite Dr. Kalpana to take part and take any questions as and when they come in. So we have quite a few questions here. Perhaps we'll only take a few. The first question is from Nikita. Nikita asks, what are the gaps in traditional family therapy training with respect to working with LGBT couples and families, and how can these gaps be filled?
Yeah, that's an emerging area. There are huge gaps, there's no doubt about it, but that's also because the number of centers that offer training in uh, basic family therapy itself is very, very limited. And therefore, in dealing with families that have LGBT issues, is I think even more limited. It is definitely something that in the future has to be focused on. But also, I'm not sure how it is in other parts of the country. There also has to be. I'm not sure how many of these families actually come forward for help, because again, this might be an issue where it is seen as an individual problem and not so much, necessity for the family to be involved.
Right,
Actually,
ma'am.
Bharat, ma'am has very clearly actually highlighted. We see in the world literature, even the world scenario. I was attending that virtual of APA, and we found that LGBTQ activists and the people who are psychologists themselves who came out a couple of months back, they were facing a lot of issues. So as Mama said that family therapy itself, the training centers in the country are limited. And on the top of that, this LGBTQ community acceptance in the country itself is a newfound law, accepted law, which has been in place. So this is the area which needs a lot of focus to work on. Maybe in future we will have this also being addressed, but it is not only in our country, it is a world scenario also. Things are developing slowly. There is a gap here.
Yes.
Thank you so much, Dr. Kalpana. The next question is from Sulata. Sulata asks, how to conduct family therapy online? Any specific precautions to be observed?
I'm sorry, I don't think I can answer that question because I have no experience of conducting therapy sessions online, but I would imagine that many of the precautions or the things that we need to observe with regard to individual therapy online, perhaps many of them would apply to family therapy. But I see a lot of foresee really practical difficulties in the sense of how do you get the required family members together for a family therapy session, online or otherwise. And frankly, I am old school, so I would much rather have regular sessions with the family in front of me rather than online.
No, I wouldn't say, ma'am, this is old school, because you are very much up to date. Because just a couple of months back, maybe 2 months back, Dr. Manoj, am I right? We had the teletherapy guidelines being released from NEMANS. So you're
True.
not old, actually. We are on the same boat. The process of growth and development is a little slow, so maybe it takes
Yeah.
time. But this question becomes relevant. But it'll take. I would say this will be included as a part of teletherapy guidelines. I refer this to for her to go through that teletherapy guidelines, which has been released by NEMANS recently. You must read that. Yes.
Great, thank you so much. The next question is from Kapil. Kapil asks, when we talk about family as a system, how is the systemic approach different from Bowen's family system therapy?
There are some differences. Unfortunately, I think maybe this is not really the forum to go into it, because Bowen talks of ego differentiation and so on, which the systemic approach doesn't really highlight. Um, Bowen's concepts are of an undifferentiated ego mass and the differentiation of different family members from the family system and so on. So there are some differences, but it's a lot more theoretical, and therefore, perhaps reading up about it would be more helpful. I don't think I can clearly put it into just a couple of points.
Sure, ma'am. The next question we have is from Jenny. Jenny asks, what are the therapeutic techniques or interventions suggested for a family, including an adult with autism spectrum disorder?
Mhm. You see, is when the session includes an adult with autism spectrum disorder. Is that right?
Yes,
Have I
ma'am.
got the question right?
Yes, ma'am.
Okay. You see, firstly, in conducting a session like that, there are some things that need to be kept in mind. First of all, what is the capacity of the individual to be able to follow spoken language and to express themselves clearly? Okay, that's one thing, because often they might have difficulties in doing that. Second, are they in a position to participate in the session? Thirdly, what would be helpful is to have maybe shorter sessions. Generally, otherwise, family therapy sessions tend to go on for at least an hour or an hour and 15 minutes, because there is, if there are at least 3 or 4 members involved, that amount of time would be required. But when dealing with a problem like autism spectrum issues and so on, the sessions itself may have to be shorter, a lot more structured, much more behavioral in its approach and orientation. Might also involve a lot of psychoeducational inputs.
Sure, ma'am. We just have 2 more questions, I guess. We have a question from Kamalika. Kamalika asks, do you have any good book or casework book suggestions?
There are a number of books. I would suggest, if people can read a book by Umbarger, that is spelled Umbarger, Karl Umbarger, that gives a very good account of systemic therapy and very clear definitions, a number of examples, and so on. So that would be a good book. Actually, Minichin's own book on families and family therapy. It's an old book, but it is still a kind of a classic. And one of the important advantages of that book is that it has sort of excerpts of interviews, between the therapist and the different family members, and that would be helpful. So those are 2 suggestions that I have.
Great, thank you, ma'am. We have one last question, ma'am, that we have time for. This is from Shivani. Shivani asks, how do you manage a situation in which a very important and significant family member is not willing to be a part of the therapy process?
Yeah. There are a couple of things that can be done. One is, first of all, we need to try and understand what is it that makes this individual so reluctant or hesitant to join in. And often enough, it turns out that these individuals are reluctant because they might fear being blamed or held responsible or attacked by the rest of the family members as a group and so on, and therefore they might be reluctant. In that case, it would be helpful if the therapist were to reach out to that individual directly by either making a phone call or sending a note across, inviting that individual to come for a session alone, individually. And in that session, the therapist can explore what are the reasons for the reluctance. And if it is possible, to try and deal with those anxieties and try and encourage the person to join in the sessions. That works sometimes. But if on the other hand you find that in this individual session you find that the individual has such a sense of alienation or being disconnected from the rest of the family, or is more or less basically indifferent to the rest of the family and their needs, then perhaps it might be just not possible to motivate them or encourage them sufficiently enough to join the family therapy session. in which case the therapist must just simply learn to work with whichever members of the family are available and not try and bring this person in. This is where, as I said, the principle of equifinality is helpful, because even if that one individual member is not available, it is possible to introduce changes through the others who are available. Okay, and that can itself bring about overall and sometimes significant changes in the family's function.
Great. Thank you so much, ma'am. Unfortunately, we've run out of time. Dr. Ahalya, thank you so much for giving us your time. It was an absolute delight having you here speaking on this platform today. I would like to invite Dr. Manoj Bajaj, Honorable General Secretary of IACP, to say a few words.
Yeah. So thank you. Good evening, ma'am. Good evening.
Good evening.
Yeah. So I attended your full of this webinar, although I was busy in the initial part, but it is quite informative and quite structured and well presented. Topic like you are a authority in this field, and I hope everybody has learned so many things from your this presentation, and thank you for taking out valuable time despite this being the new platform of presenting something in a way that people get maximum understanding of certain concepts. And family therapy is being practiced in very limited areas, limited centers. And NIMHANS is one of the pioneer in this, and you are the authority in this area, who has given us time for our members and taking out so much of time and presenting in a very structured manner. I was very happy to see you again. I met you in the conference, and now I'm seeing you here, the same enthusiasm and the same involvement while presenting this topic. So thank you very much for taking out so much of time, and I thank you, President Madam, also for arranging talking to you and discussing and arranging this particular topic for our members. And I think everybody who is the participant today and who has attended this webinar, it is well received by maximum people. I saw there were more than 400 members who have joined today in this webinar. It is one of the most you can say one of the best received webinar of IACP today, and I congratulate you for your this engaging people for so much of time during this period. And online system, it is also very you can say praiseworthy. And thank you, ma'am. Thank you, everybody. Thank you, Pearson, for providing technical support for arranging this particular series of webinars from the IACP. So thank you, ma'am. Thank you, President, ma'am. Thank you, everybody.
Yeah. Thank you.
Thank you so much, sir. Dr. Kalpana, any last words before we can conclude?
No, that's fine. Thank you, everyone. Thank you.
Thank you. I want to thank all of our viewers for the strong interest in the webinar. I look forward to meeting you all for the next Pearson Learning webinar. Please check your emails for upcoming webinars. We also have a podcast for mental health professionals called The Echo. You can find it on our YouTube channel. We will, of course, be sharing this recording of the webinar with everyone who have registered by tomorrow. With that, we end this session. I hope you've enjoyed this learning as much as we've enjoyed delivering this learning to you. Once again, thank you for sparing your time for this session, and have a great day.
Thank you.